expert, Shafinaz Sabudin, and the topic for today is nodular lymphocyte predominant Hodgkin disease and T-cell histiocyte-rich large B-cell lymphoma, addressing the diagnostic dilemma. So before we start, allow me to briefly introduce our speaker. Dr. Shafinaz Sabudin graduated from University of Western Australia in 2000 and obtained her Masters of Pathology in Anatomic Pathology from University of Malaya in 2011. And she had done her special interest in lymphoreticular pathology in Hospital Queen Elizabeth, Kota Kinabalu, Sabah in 2018. So she is currently a consultant histopathologist in Hospital Raja Permaisuri Baino Ipoh, and she's our referral person for lymphoma cases in Ministry of Health Malaysia. So without further ado, please welcome Dr. Shafinaz to deliver her talk.
Hi, Assalamualaikum everybody, and good morning. Can you hear me?
Yes, Dr. Shafinaz.
Okay, good. Okay, today I'm going to talk about nodular lymphocyte predominant Hodgkin lymphoma and T-cell histiocyte-rich large B-cell lymphoma, addressing the diagnostic dilemma. Okay, let me share my screen. Right. Okay. Nodular lymphocyte predominant Hodgkin lymphoma is anti-T-cell histiocyte-rich large B-cell lymphoma is two distinct entities. However, it is important to recognize that nodular lymphocyte predominant Hodgkin lymphoma has got some variant patterns, and the variant pattern is the one have overlapping features with T-cell histiocyte-rich large B-cell lymphoma, and these are the ones that give some confusion and also diagnostic dilemma for us, the pathologists, when we are dealing with our tissue biopsies. Okay, they are actually two distinct entities. Most of the time, we can distinguish them based on our clinical input, the histopathological and immunohistochemical grounds. However, on some lesser instances, which when we are facing with the variant pattern, we will talk about the variant pattern in a moment, it will be very difficult to distinguish between these two entities. And this is the one that poses a challenge to us to make a correct diagnosis. Considerable histopathologic and immunophenotypic overlap of these two entities suggests that actually both of these two entities are closely related, and they may constitute a pathobiological spectrum. Okay, why is it important for us to make the correct diagnosis and to distinguish between these two entities? It's very important because they have very different clinical course and prognosis. So patients will receive very different treatment strategies and have very different prognostic factors. So it is very much a burden to us to make correct diagnosis for this purpose. Okay, today, the aim of the talk, we will get to know a little bit of nodular lymphocyte predominant Hodgkin lymphoma and T-histiocyte-rich B-cell lymphoma. Not that we don't know them, just as a reminder for me and for all of us. We will try to identify what are their specific features and what are the overlapping features in terms of their clinical presentation, their biologic morphology spectrum, how do we assess the nodular architecture, what are the cellular and microenvironment, which is very important, what are the immunophenotypes, and what are the genetic expression of these two entities. And we will also briefly touch on what are the differential diagnoses that we need to consider along the line. And then we will try to conclude. Okay, let's start. Nodular lymphocyte predominant Hodgkin lymphoma. This is actually a very rare type of Hodgkin lymphoma. It only accounts of about 5% of total Hodgkin lymphoma cases. Most frequently, it occurs in young adults, of 30 to 50 years of age, and usually it's more seen in male patients. Most of the time, more than 75% of patients, they present at stage 1 to 2 disease, meaning this is a very indolent, low-grade lesion. Typically, it only involves peripheral lymph nodes. Patients are generally well. They do not have any B symptoms. They do not complain of any fever, malaise, loss of weight, or loss of appetite. And there is no extranodal tissue involvement, such as the mediastinum, or the liver, or the spleen, or even the bone marrow. It is a slowly progressive disease with multiple relapses, but they usually remain responsive to therapy. The 10-year overall survival is very good, which is more than 80%. However, a small percentage of these cases, which is about 3 to 15%, have the high risk of progression to high-grade large B-cell lymphoma. This is the one that is categorized under the variant pattern of nodular lymphocyte predominant Hodgkin lymphoma, where they present at initial presentation with a higher stage disease, and they have a very high risk of relapse and also high risk of progressing into higher grade of large B-cell lymphoma. So we will focus quite in detail about the variant patterns. Okay, now, what do we do when we see nodular lymphocyte predominant Hodgkin lymphoma under the microscopy? So there are a few things that we need to assess when we encounter nodular lymphocyte predominant Hodgkin lymphoma. First and foremost, we need to look at the architecture of the tissue. What is the growth pattern look like? As I mentioned earlier, most of the time, nodular lymphocyte predominant Hodgkin lymphoma will be dominated by large nodules. Under the H&E section, you can see a lot of large abnormal nodules, which compose of reactive small B cells in the background. And LT cells are only intermingled among these small B cells. And the nodules are supported by large expanded follicular dendritic cell meshwork. These are mainly the majority of the nodular lymphocyte predominant Hodgkin lymphoma growth pattern. They are mostly in nodular form. However, there are some exception or some variation. So in lesser cases, there is an admixture of nodules and diffuse areas or totally diffuse areas. So this is where the researchers or the pathologists who are interested in the study of nodular lymphocyte predominant Hodgkin lymphoma have come up with patterns of the architecture, which is very important because from these patterns, we can predict what is the patient going to end up with at the end of the treatment, whether it is a high-grade disease, whether they have a high possibility of transforming into high-grade B-cell lymphoma. So basically, there are 6 patterns of architecture: pattern A, B, C, D, E, and F. Pattern A and B is the typical classical nodular pattern, which we most of the time encounter when we assess nodular lymphocyte predominant Hodgkin lymphoma, which is pattern A, you have typical B-cell rich nodular. Pattern B is a serpiginous nodular. Pattern C is still nodular, but you have a lot of prominent extranodular LP cells. Pattern D is still nodular, but the background cells are now composed of T-cell rich lymphocytes. And pattern E is diffuse pattern, and they have the T histiocyte rich B-cell lymphoma-like pattern. And pattern F is a diffuse pattern with B-cell rich in the background. So pattern E is the one that have the most similar overlapping feature with T histiocyte rich B-cell lymphoma. Okay, this is the schematic diagram of what I've just mentioned of all the patterns A till F, with the correlating with the CD20 stain next to each pattern. Okay. So in pattern A is the classical. You see the huge nodule which is made up of B lymphoid cells in the background, and the LP cells are intermingled within the nodule. And these are highlighted by the CD20 immunostain, the nodular configuration. In pattern B, it is the serpiginous or interconnected. It is still nodular, but now you see the nodularity is irregular, or it is interconnected. And it is made up of B cells in the background, and you can see the LP cells are predominantly within the nodule. And this is highlighted by the CD20 immunostain. Okay. Now the next pattern is pattern C. Pattern C is also still nodular, as you can see on the CD20 immunostain, but now you can see some LP cells being highlighted by the CD20, which is located outside the nodule. So this is the prominent extranodular LP cells. So this is the wrong one. The LP cells in the background, okay? And pattern D is still nodular, but now within the nodular, it is not picking up any B small lymphocytes. It is now rich in T cells, but CD20 highlights the LP cells. Okay. Now pattern E is the one that has got the most similarity with the histiocyte-rich B-cell lymphoma, and so the name is the histiocyte-rich B-cell lymphoma, or DLBCL-like pattern. It is a diffuse pattern. You don't see any more nodular configuration, and it is dispersed with all these large LP cells. And pattern F is diffuse moth-eaten architecture, and the background is dominated by B-cell lymphocytes. Right, so you may want to ask, what is the clinical impact of these growth patterns? There are many studies that have been done throughout the years, and this is one famous study by the German Hodgkin study group, where they look at 432 patients that has been diagnosed with nodular lymphocyte predominant Hodgkin lymphoma. And most of the patients, 75% of the patients, present with patterns A and B, which is the typical nodular classical growth pattern. 25% of the patient exhibit variant pattern, either is C, D, E, or F pattern. So what they found out, that variant pattern is associated with advanced disease and higher relapse rate. It is also found to have persistent at recurrence. And it is also correlated with a shorter time to progress to higher grade B-cell lymphoma. And usually they will present with higher stage disease, and they have lower complete response, and they have more frequent relapse. So meaning to say that variant pattern is very important to be identified, especially pattern C and pattern E, because they usually will present with advanced clinical stage disease, and they will relapse more frequently. They will be resistant to chemotherapy, and they have the higher tendency to progress to higher grade large B-cell lymphoma. So apart from the German Hodgkin study, there are so many other studies that have been done. The similar, where they have all increased rates of relapse, presentation with high diseases, and so on. Okay, that is the architecture assessment. Now, next important architecture to assess in nodular lymphocyte Hodgkin lymphoma is presence of measure of follicular dendritic. As I have mentioned earlier, the nodula are made up of expanded cell measure. This is usually found in patterns A, C, and and you can highlight by using states like the CD23 or CD51, and the classic cell present within the however, some variant patterns, there is fully or partially loss of the nodular pattern, whereby you only see diffuse areas on H&E staining. So in these cases, it is crucial to do the CD21 or CD23 immunostain to detect the presence of residual FDC meshwork, which is in association with LP cells and the small B cells. If you find such areas, then it is sufficient to exclude T histiocyte-rich B-cell lymphoma, and it may be a variant pattern of nodular lymphocyte predominant Hodgkin lymphoma. So performing CD21 and CD23 to look for residual follicular dendritic cell meshwork is very crucial in our workup. Okay, next, we look at the morphology of the LP cells. The LP cells are scattered, large, atypical cells with multilobated vesicular nuclei, prominent nucleoli, and abundant cytoplasm. This is a picture of it. You can see there's a single LP cell with a very large, irregular, multilobated nuclei and a prominent single nucleoli and scant cytoplasm, and it is embedded within a rich background of small lymphocyte and some histiocyte. Okay, next we also need to assess the tumor microenvironment, meaning the cellular background. The nodules are predominantly filled with small B lymphocytes and varying numbers of T cells. The T cells are of T follicular helper type. So these T follicular helper type, they form rosettes around the LP cells. In most of the nodular lymphocyte predominant Hodgkin lymphoma cases, but in T histiocyte-rich B-cell lymphoma, they are absent. So if there is a total absence of small B cells, very low numbers of T cells of T follicular helper type, but it has got dominance of cytotoxic T cells, so it more in favor of T histiocyte-rich B-cell lymphoma than nodular lymphocyte predominant Hodgkin lymphoma. Okay, other things that you can also assess is to see whether there is any presence of reactive follicular hyperplasia with or without PTGC. PTGC is progressive transformation of germinal center adjacent to the nodular lymphocyte predominant Hodgkin lesion. If it is present, then it's more in favor of a nodular lymphocyte predominant Hodgkin lymphoma. And also you can also assess for remnants of small germinal centers in the tissue. If it is present, then it is more likely to be the classical Hodgkin lymphoma lymphocyte-rich differential diagnosis. So, in conclusion, when we are trying to diagnose nodular lymphocyte predominant Hodgkin lymphoma, it requires immunohistochemistry to outline the architecture growth pattern and also to ascertain the phenotype of the tumor cells and also the cellular microenvironment. And also, of course, you have to do marker to establish presence or absence of follicular dendritic cell meshwork. Okay, this is basically a summary, a diagram that summarizes everything that I have just said, where you have pattern A and pattern B with its associated follicular dendritic meshwork, the localization of the LP cell, whether it's within the nodules or whether it's outside nodules, whether there is a predominance of B or T cell in the background, the microenvironment. So yeah, so this, I think this diagram is pretty important if we want to fully understand the variant patterns of nodular lymphocyte predominant Hodgkin lymphoma. So just bear in mind that some of the variant pattern, they are very similar and they have the overlapping features with T histiocyte-rich B-cell lymphoma, especially pattern E. And on clinical presentation also, they are of a higher, they present with higher stage disease and with higher rate of relapse and progression to a higher grade of B-cell lymphoma. Right, so the immunophenotype, what are the things that we need to do when we are assessing nodular lymphocyte predominant Hodgkin lymphoma? So the LP cells, they are actually B cells. So they will be picking up all the B cell markers and LCA. So CD45 will be positive, 20, 79A, BCL6, MUM1, OP2, BOP1, PEX5, EMA, and CD15 and CD30, which we routinely use to assess classical Hodgkin, are usually negative. The nodular cellular composition, the small B cell profile, they are of B cell phenotype as well. So they usually will pick up all the B cell markers and also IgD. They are of mantle cell origin. And the T cells, which I mentioned of the T follicular helper type profile, so they will be expressing T cell markers, especially CD4, and also T follicular helper marker, which is CD57 and PD1. The histiocytes, you can do, the profile will be CD68 positive, and the follicular dendritic cell measure, you can do CD21 and CD23. So these are basically the important immunohistochemistry to do when assessing nodular lymphocyte predominant Hodgkin lymphoma. Okay, these are some of the stains and how it looks like under the IST slides. The first row here is how CD20 and highlights the nodular configuration and how they also stains the background, majority background B cell lymphocytes, as well as the LP cell. Other B cell markers, CD79A, will also highlight the similar information, as well as PAX5 and also OCT2-BOT1. OCT2-BOT1 will strongly highlight the LP cells within the background B cell lymphocytes. CD21 is how we use to assess for follicular dendritic cell meshwork. And T cell markers, CD3 and PD1, is used to assess the T cell in the background and also to highlight the rosetting pattern. Even under CD3, you can see some rosetting pattern where it rosettes the LP cell. And this is better seen under PD1 immunostain, where the PD1 and circles are forming rosettes around the LP cell. This is basically telling you the same story. Okay, so that is basically what you need to know for nodular lymphocyte predominant Hodgkin lymphoma histology. Okay, now what is the triggering factor for the lymphoma genesis in nodular lymphocyte predominant Hodgkin lymphoma? There are so many studies that have been done, and there are some growing findings that it is actually associated with bacterial infection, and Moraxella catarrhalis is one of the most frequently found in the RNA polymerase study. Okay, as I mentioned earlier, the importance of the variant to recognize the variant pattern is because they have a higher risk of progression or transforming to a higher grade B cell lymphoma. So when they transform, these are the factors that we need to look for. Loss of nodular architecture and FDC meshwork. The large B cells or the LP cells are diffusely scattered, which is a characteristic of T histiocyte rich B cell lymphoma, or they form confluent sheets, which is a characteristic of diffuse large B cell lymphoma, transforming into diffuse large B cell lymphoma. And also the cellular background, in the background, there is a transition from a B cell rich microenvironment to T cell histiocyte rich microenvironment. If you see this picture on the left side, you can see the progression. The first picture here shows the T histiocyte rich large B cell lymphoma-like architecture where it's dispersed singly and the background is of T cell rich. And as it goes further down, you can see they are starting to form aggregates and solid sheets, and which is characteristic of diffuse large B cell lymphoma. However, we have to bear in mind that individual cases can show wide variation, so may not reliably predict the clinical behavior. Right. So as we have mentioned earlier, the T histiocyte rich large B cell lymphoma-like areas of nodular lymphocyte predominant Hodgkin lymphoma, which is pattern E, is the one that shows many overlapping features with T histiocyte rich large B cell lymphoma. And to make this diagnosis of pattern E nodular lymphocyte predominant Hodgkin lymphoma or T histiocyte rich large B cell lymphoma is very challenging if we only receive needle core biopsy, because it may not be sufficient to capture nodular or diffuse areas. So the gold standard for us to diagnose nodular lymphocyte predominant Hodgkin lymphoma is by surgical biopsy. Okay, that is about nodular lymphocyte predominant Hodgkin lymphoma. Now we go to T cell histiocyte rich large B cell lymphoma. This entity, they may arise de novo, that is on its own, or it can progress or transform from nodular lymphocyte predominant Hodgkin lymphoma, as we have discussed earlier. De novo T histiocyte rich B cell lymphoma is a rare entity. It typically presents in middle-aged patients with male predominance. It is usually associated with advanced stage at presentation. They usually present with systemic involvement. Patient will come in with fever, malaise, and they have extra nodal organ involvement such as the spleen, the liver, bone marrow. So this information is very crucial and you need to ask from the clinician. And more than 50% of the patient, they present with advanced stage at presentation, and usually they follow an aggressive course, and they are often refractory to chemotherapy. Okay, however, having said that, you need to also recognize that there is a heterogeneity in the clinical behavior. Especially some cases, some patients have been reported to have less aggressive disease course. And this patient may be the ones that who likely progress from a known or previously unrecognized nodular lymphocyte predominant Hodgkin lymphoma. The only way to give a prognosis for this T histiocyte rich large B cell lymphoma is by using International Prognostic Index, and they usually highly correlate. There is a lack of strong ancillary tests, whether by immunohistochemistry, by molecular markers, to separate de novo T histiocyte rich B cell lymphoma from those that progress from nodular lymphocyte predominant Hodgkin lymphoma. So again, I would like to emphasize here that pattern E of nodular lymphocyte predominant Hodgkin lymphoma shows the most significant overlap with T histiocyte rich B cell lymphoma, and this is the one that will give major confusion for us, or the diagnostic dilemma for us when trying to diagnose nodular lymphocyte predominant Hodgkin lymphoma. Okay, let's look under the microscope. How does T histiocyte rich large B cell lymphoma look like? When we assess the architecture, it has got diffuse growth pattern, replacing most of the lymph node parenchyma, and it composed of scattered limited number of single large B cells. Usually it's less than 10% of the tumor mass, which is embedded in a background of small T cells and variable numbers of histiocytes. They do not form aggregates or sheets. There is no associated nodular component. FDC measure is not identified, both on H&E and immunohistochemistry. If there is presence of FDC measure, then T histiocyte rich B cell lymphoma is excluded, and you need to consider pattern E variant of nodular lymphocyte predominant Hodgkin lymphoma. Okay, the morphology of the tumor cells, they have greater variation in sizes and cytological features. Sometimes they mimic LP cells, sometimes they mimic RS or Hodgkin cells, or sometimes they may be of the centroblastic and immunoblastic morphology. They are typically found within clusters of bland-looking non-epithelioid histiocytes. Okay, the tumor microenvironment, which is the cellular background, of course, you don't see any meshwork. Other inflammatory cells are rare. The background lymphocytes are of T cell lineage of the cytotoxic phenotypes, and they have a lot of histiocytes. These cells are very few or hardly present. This is a diagram, a picture showing a single tumor cells which have got a large nuclei, vesicular nuclei, and prominent nucleoli, which is embedded in the background rich in small lymphocyte. and histiocytes. And this cell, the tumor cells are highlighted by the CD20 stain, and the background T cells are not picking up the CD20 stain. The immunophenotype, the tumor cells are also of a B phenotype, so they will be expressing most of the B cell markers, and they are negative for CD3, CD15, CD30, CD138. The cellular background, they are of T cell profiles, which is a cytotoxic phenotype, so they will be expressing T cell markers, especially CD8, cytotoxic markers, and rosettes of tumor cells are not present. The histiocyte profile, you can highlight them by using CD68 and CD163 immunostain. It's also important to consider aggressive B-cell lymphoma rich in reactive T cells and very sparse tumor cells by using EBV stain in addition, because you want to also rule out EBV positive DLBCL, especially in elderly age group. Okay, that's it about the both nodular lymphocyte predominant Hodgkin lymphoma and T histiocyte rich B-cell lymphoma. Now we go to the explanation as to why there are so many overlapping features and also the variant pattern of the entities. It's basically explained at the genetic or the molecular level. Nodular lymphocyte predominant Hodgkin lymphoma, they derive from germinal center B cell at the centroplastic stage of differentiation. T histiocyte rich B cell lymphoma also arise from the germinal center B cell arrested in terminal B cell differentiation. So from here, you can see that how closely they are in terms of their location of mutation in the germinal center area. So that is why they share so many genetic characteristics of both activated B cells and also germinal center B cells. There are so many studies that have done, and the studies have showed that they have many similarities on the genetic level. Some of the similarities are they both carry clonally rearranged and somatically hypermutated immunoglobulin gene with evidence of ongoing somatic hypermutation. And there is also persistent BCL6 rearrangement, which further confirm their relationship with germinal center B cell. Comparative genomic hybridization studies have also done, and they also show many genomic aberration, and the genomic aberration are being shared in both these entities. Such, for example, there is gain 2p16.1 and losses of 2p11 and 2 and 9p11.2. And they also both express REL protein. And when they look at the microenvironment cells, the microdissect histiocytes, and even the microenvironment cells also express similar genes, which are related to pro-inflammatory and regulatory macrophages activities. Apart from BCL6 gene rearrangement, there are so many other genes that have been shown to share common expression in both nodular lymphocyte predominant Hodgkin lymphoma and de novo T histiocyte rich B-cell lymphoma. So this, with the sharing of so many genetic aberration, genetic mutation, this may suggest the possibility that T histiocyte rich B-cell lymphoma may represent a variant extension of nodular lymphocyte predominant Hodgkin lymphoma at the extreme end. This speculation is supported by the observation that pattern E, especially pattern E of nodular lymphocyte predominant Hodgkin lymphoma, show the T histiocyte rich B-cell lymphoma-like transformation, and they are indistinguishable from de novo T histiocyte rich B-cell lymphoma. So overall, more recent expression profiling and genetic studies have revealed similarities between nodular lymphocyte predominant Hodgkin lymphoma and T histiocyte rich B-cell lymphoma that suggests these entities may constitute a pathobiological continuum with various clinical presentation. So this continuum from the typical classical nodular lymphocyte predominant Hodgkin lymphoma into the variant pattern and into the well-established T histiocyte rich large B-cell lymphoma and DLBCL at the extreme end is highly being recognized, where they have overlap in architecture, the LP cell distribution and frequency, the microenvironment composition, the gene expression profiling signatures, and the next generation sequencing mutation profiles. They all share these similarities. However, important to note here that there is no criteria of cutoff for the diagnosis has been established so far. So more studies with large numbers of rare variants and borderline cases are needed to better define these boundaries so that we can better understand and we can better distinguish between the nodular lymphocyte predominant Hodgkin lymphoma, T histiocyte rich large B-cell lymphoma, the LBCL spectrum. Okay, this is a study that also looked at the global gene expression analysis of nodular lymphocyte predominant Hodgkin lymphoma and T histiocyte rich large B-cell lymphoma, but they also found out not only they share similarities, both of them, but they also share some similarities with classical Hodgkin lymphoma, where all these subtypes, they show some loss of down regulation of the B-cell program. From this study, they found out. And they also established the isolated LP cell defined in the nodular lymphocyte Hodgkin lymphoma as a distinct entity closely related to T histiocyte rich B-cell lymphoma and classical Hodgkin lymphoma. And also they found out that there are so many genes, as I mentioned earlier, that are similar with nodular lymphocyte predominant Hodgkin lymphoma and the LBCL. So this study also is consistent with the reported biological and phenotypically relatedness of these lymphomas. Okay, what is the emerging concept of genetic in nodular lymphocyte predominant Hodgkin lymphoma? The latest one is the next generation sequencing, where they use this technique to predict transformation risk of nodular lymphocyte predominant lymphoma. And they can also establish more mutational profilings of the LP cells, the microenvironment cells, and they study immune-related pathogenetic mechanism. So they can explore novel therapeutic approaches with less toxicity to the patient, which is a good beneficial input to the patient. And also there are recent advances in multiplexing and computational technologies, where it allows precise measurements of spatially resolved configurations pertinent to the tissue architecture and cell composition, which will provide new avenues for future research. So this is the diagnostic boundaries that we have found from all the genetic studies that have been carried out. So there is overlapping features of nodular lymphocyte predominant Hodgkin lymphoma, diffuse large B-cell lymphoma, and classical Hodgkin lymphoma. We need to appreciate these overlapping features. Okay, apart from those, there are also other diagnostic mimics and overlaps that we need to know, because when we are doing the workup, we need to also consider these lymphomas. Are we dealing with them, or are we really dealing with nodular lymphocyte predominant Hodgkin lymphoma and T histiocyte rich B-cell lymphoma? Okay, one non-neoplastic lesion is progressive transformation of germinal center. This non-neoplastic lesion, they can be synchronous or metachronous, and they can co-occur with nodular lymphocyte predominant Hodgkin lymphoma. So when we do the tissue assessment, we need to look for areas with PTGC component and looking for the LP cells. Both have got irregular expanded follicles with disruption of the germinal center as well as the mantle cell areas. But the thing to distinguish between these two is by looking for the LP cells and the T follicular helper cell rosetting the LP cells. And if it is very difficult to look in the nodule itself, we can try looking in the extranodular areas. And immunohistochemistry can aid us in identifying the LT cells and the T helper cell rosetting the LT cell. Okay, next is neoplastic lesion. As I mentioned earlier, with the classical Hodgkin lymphoma lymphocyte rich, but this one usually we will identify them by using immunohistochemistry, because the classical Hodgkin lymphoma will be positive for CD30 and CD15, and sometimes it has got a heterogeneous expression of CD20 as well. Another important mimicker is the T-cell lymphoma. Since there is very intense T cells in the background in some of the variant pattern, especially pattern D, E, and F. Not F, N. Okay, in pattern D and E. So the possibility of us being misled by these rich and dense T cells in the background to T-cell lymphoma is possible, especially when we do stains and we found out that the T cells in the background are having T follicular helper phenotype, meaning which is similar to the nodular lymphocyte predominant Hodgkin lymphoma microenvironment T cell phenotype. So we may most of the time confuse ourselves with angioimmunoblastic T cell lymphoma and PTCL and OS subtypes. But one way to clarify is by doing the markers to identify the LP cells. So in this picture, they use PAX5 to identify the LP cells, and also they do PD1 to look for the rosetting around the LP cells. So if you see areas with this kind of arrangement or pattern, then it may be most likely to be nodular lymphocyte predominant Hodgkin lymphoma rather than T-cell lymphoma. So it is very important for us to also have this at the back of our mind when we are doing our work. Think of the non-neoplastic PTGs. Think of the lymphomas of classical Hodgkin lymphocyte rich, and think of lymphomas of the T phenotype. Okay, now that we have understood the pattern, the arrangement, the immunophenotyping of all the components in the tissue, and also what the explanation at the genetic level. So how do we address the diagnostic dilemma in our clinical routine practice? So it comes down to a few points to ask ourselves, like a checklist during our workup. First is the clinical presentation. Is it a localized or a systemic lesion? Is it indolent or is it aggressive disease? Then we look at the nodal architecture. What is the growth pattern? What is the tumor cell morphology? What is the microenvironment made up of? The presence of follicular dendritic cell meshwork, the phenotype of the cellular background, whether there are presence of PTGC, residual germinal centers or lymphoid hyperplasia. What are the immunophenotype that is carried by the tumor cells, the microenvironment cellular background, as well as whether there is presence or absence of follicular dendritic cell meshwork. And also beware of the differential diagnosis, and also the mimickers and the pitfalls. And most importantly, you need to have close communication with your clinician. Okay, in summary, nodular lymphocyte predominant Hodgkin lymphoma and T histiocyte rich B-cell lymphoma are both B-cell lymphomas. You must remember that nodular lymphocyte predominant Hodgkin lymphoma have variant patterns, and the recognition of the variant pattern is very important because it has got overlapping features with T histiocyte rich B-cell lymphoma. There is also overlap in tumor microenvironment cell types and composition, gene expression signatures, and mutational profiles, which explain the close relatedness of nodular lymphocyte predominant Hodgkin lymphoma and T histiocyte rich B-cell lymphoma, both biologically, phenotypically, and clinically. So this is the fundamental explanation as the presence of the variant pattern and the overlapping features. So wholesome approach of clinical inputs, microscopic assessment, immunophenotype, and genetic knowledge will somehow help us in making up our mind to make the correct diagnosis. And also we must be aware of mimicus, pitfalls, and other differential diagnoses. Okay, these are my reference. With that, I thank you.
Thank you, Dr. Shafinaz, for sharing your knowledge. It's a very clear, comprehensive, interesting talk. I learned a lot this morning. I'm sure all of us do. Yeah, indeed, these two entities are sometimes can be very difficult to be distinguished, especially in the small core biopsies. So now we have about 10 minutes. I open to participants to ask questions. You can unmute yourself and please feel free to ask questions if you have any. Or you might want to type in the chat box and I will read for you. So far, there's no question in the chat box.
Sorry, can I just mention that this recognition of the variant pattern and also the importance of its overlapping features with the T histiocyte rich B-cell lymphoma has been added to the latest edition of WHO classification, the 5th edition, which will be soon released. I don't know whether this year or next year. So yeah.
Yeah. So we are expecting a new WHO coming out. I think quite soon, hopefully.
Yeah. I can share with you the review article if I let me see.
Yeah.
Can you see or not?
Not yet.
Can you see? No,
Not yet.
Wait, let me try again. Okay. Okay, this is the latest review. Can you see?
Yes.
Okay, this is the latest review article where they have updated the WHO classification of hematolymphoid tumors, the lymphoid neoplasm, the 5th edition. So in this latest edition, they have added the variant of nodular lymphocyte predominance, Hodgkin lymphoma. Then they have recognized the overlapping features of the variant pattern, especially pattern E, with T histiocyte rich B-cell lymphoma. Let me show you the page. Okay, this is the edition where they have put the immunomorphological growth patterns of nodular lymphocyte predominant Hodgkin lymphoma, all the 6 patterns that we have discussed. And in the text, they have also acknowledged regarding the overlapping, the different, as I highlighted here, let us read. An important issue in nodular lymphocyte predominant Hodgkin lymphoma is the recognition of the different growth patterns overlapping with T-cell histiocyte-rich large B-cell lymphoma at the extreme end. And then some variant patterns, especially pattern C, D, and E, have been associated with more aggressive clinical behavior. And what else? Okay. And a clear distinction between nodular lymphocyte predominant Hodgkin lymphoma pattern E and T histiocyte-rich B-cell lymphoma may not be possible, since both diseases present with advanced clinical stage. Distinction is especially difficult on small biopsies, which may not be representative. So they have actually recognized this difficulty and have added it into the latest edition of the WHO classification of lymphoid neoplasm.
Yeah. So Dr. Shafinaz, I just have one question since there's no question from others. So from what I gathered from this talk is that not only the morphology of the LP cells or the large B cells are important, the morphology and the immunophenotyping of the tumor cells, but also the microenvironment is equally important. So we have to also look at the background lymphocytes, whether they are T-rich or B-cell-rich, presence of histiocytes, the nodular architecture, which is sometimes difficult to see, especially in the through cut a small,
Yes.
slim cord biopsy.
Yes.
So the demonstration of the follicular dendritic cell mesh is also important. So there are two markers that we have, which are CD21 and CD23. So
Yeah.
between these two, would you do both, or can we just do one, or any difference between these two, or they are equally they are equal?
Usually they will express similarly, but if some centers they have only CD21, or some centers they have both, or some other centers they only have CD23. So it depends on what your availability at your center. I think most of the time it will highlight this, it will give you the similar information.
All right, thank you, Dr. And another one is that, can I just ask, another differential for these two entities is the lymphocyte-rich classical Hodgkin lymphoma. And usually, most of the cases that we have clear-cut immunophenotyping. In classical Hodgkin lymphoma, they will clearly express CD30, PAX5 will be dim, CD15 will be positive, and they are usually negative for CD20. But in some instances, the Hodgkin cells, they can have heterogeneous CD20 expression, like you mentioned in your talk. Any other markers that we can do to to help us to differentiate from lymphocyte, the NLPHD, which is CD20 positive?
Yeah, we usually I will do I will proceed with other B cell markers like CD79A, and also other nuclear transcription factors like OCT2 and BOP1, which most of the time will be negative in classical Hodgkin, and will be strongly expressed in nodular lymphocyte. Another thing that I would do is I would perform EBV immunohistochemistry if you have, or usually in my center we have EBV-ish. So that would also help to distinguish between nodular lymphocyte predominant Hodgkin lymphoma and classical Hodgkin, because research has shown that classical Hodgkin lymphoma, they have a higher propensity to express EBV. So this would be some of the tools to help you differentiate between these two entities.
Okay, thank you, Dr. Shafinaz. There's one question from Dr. Gan Sun Ching. May I ask, if we don't have PD1, OCT2, BOP1, and cytotoxic markers, can we still diagnose or differentiate between the two? I suppose between the nodular lymphocyte predominant Hodgkin lymphoma and T histiocyte-rich B cell lymphoma.
I think on the normal happy days where you get nodular architecture, when you can already diagnose as a nodular lymphocyte, maybe you do not need to have the markers. These are usually considered as the third panel, or the more advanced panels, right? But on your gloomy days, when you get core needle biopsies and you cannot differentiate, or you cannot assess further for the presence of FDC meshwork, or LP cells are very sparse, then I suppose you still need this marker. Well, if you don't have, that is where the challenge is. Or you can send over to us, to perform the markers, because we do have these markers in our center.
Yeah. Thank you, Dr. Shafinaz. We have 4 more minutes. If anyone have any question, you can just unmute yourself.
Dr. Shafinaz Sagunaya. I just have one question. In the case of a needle core biopsy, if we cannot differentiate between these entities, how to write the interpretation and save comment?
You can give a descriptive interpretation where you can say that the morphology looks like either LP cells or or centroblastic or whatever, which express B cell phenotype. Differentials include nodular lymphocyte of whatever variant pattern that you are suspicious of, and T histiocyte-rich B cell lymphoma, and you comment that core needle biopsy is insufficient to assess for the presence of nodular architecture, and you need to to ask them to repeat excisional biopsy, which is the gold standard if you want to diagnose nodular Hodgkin lymphoma. You can give a broad interpretation saying, of course, these two are of B phenotype. That is quite safe to say, but you cannot decide. The close differentials are nodular lymphocyte, whatever variant pattern that you're thinking of, and T-histiocyte rich B-cell lymphoma. I would do that and ask them to exercise a complete lymphoma.
Okay, thank you for the explanation.
All right, thank you, Suguna, for the question. Any more questions? We have 2 more minutes. So if there's no more question, I think we can end this session. Before we end, I would like to once again thank Dr. Shafinaz for a very comprehensive talk. And I also would like to thank the IAPMD Weekend Organizing Committee for creating this platform, which I think is very beneficial. And I hope this session will continue. So that's all from me. Thank you so much. Thank you, Dr. Shafinaz.
My pleasure. Bye.
Bye. Stay safe and Assalamualaikum, everyone.
Thank you, Dr. Shafinaz, on behalf of the IAPMD committee for the great talk. It's very crystal clear talk. And for the upcoming events, we have a few continuous events coming soon. And then for the next week, we have a Purifying Weekend with IAPMD live title Stepping Stones to a Proper Renal Biopsy Reporting by Dr. Hemlata Kumari. This is another great topic. And for the participant who attended today, we will provide the certificate in a usual manner through email. So thanks again to Dr. Shafinaz and Dr. Asmawiza Awang to lead us in this talk today. And thank you, participants, for joining us today. See you all next week.